Well, very much welcome to this session. It will be recorded and BJS Prize presenters will also present in English. I will have a short background in Swedish first. You're very much welcome. För det är lite kort bara, och det här är till svenskarna så det behöver vi inte spela in så att alla engelsmän hör. Men BJS Prize är ju ett relativt nyinstiftat pris där BJS Society tillsammans med då Svensk kirurgisk förening, vi är ju så kallade strategic partners som ni har hört tidigare, bedömer olika priser och man har möjlighet att publicera i BJS eller BJS Open. Och den här abstraktinlämningen den sker i april och den går då till Svensk kirurgisk förening och sen bedöms den tillsammans då med KKF, alltså Kommittén för kirurgisk forskning, med BJS representanter. Och det är endast betalande medlemmar i Svensk kirurgisk förening som kan göra det här. Så ni som har skickat in och inte är medlemmar, de blir inte bedömda. Det är jätteviktigt att ni vet det. Och som sagt var, Chief Editors och KKF bedömer ungefär 4 till 6 submitterade manus. Och de här har då möjlighet att bli publicerade. Det är inte ett löfte, men de kan bli publicerade i BJS eller BJS Open. Vinnaren, och vi kommer idag ha några nominerade som ska presentera, och vi kommer också berätta i slutet vilka som är vinnare. Och då första pristagaren vinner 3 500 euro och andra pristagaren 1 500 euro. Och som sagt var, i slutet av den här presentationen så kommer ni få veta det, så spänningen är olidlig. De nominerade är Matilda Annebäck, Marta Berndsen, Pamela Buchwald och Emelie Nilsson och Roberto Rosén. Och jag börjar med att be att Matilda Annebäck kommer upp på scen. Hon har skrivit en studie som heter Quality of Life in Patients with Permanent Hypoparathyroidism after Thyroidectomy. Välkommen Matilda.
Tack. Good morning. I would like to start by saying thank you to the organizing committee and the BJS for the opportunity to present our work for you today. In recent years, some studies have reported that permanent hyperparathyroidism have a negative impact on health-related quality of life. However, the data is limited by short-term follow-up, possible selection bias, and varying definitions of permanent hyperparathyroidism. Also, most studies compare quality of life in patients with permanent hyperparathyroidism to the general population and are therefore likely to overestimate the impact of permanent hyperparathyroidism, since the hypothyroid state after surgery and the thyroid disease leading up to the surgery may also impact the well-being in patients undergoing thyroidectomy. So in this study, we have tried to minimize the effects of the potential co-founding variables in previous data. And the aim was to investigate quality of life in patients with or without hyperparathyroidism after total thyroidectomy for benign thyroid disease, using a strict definition of permanent hyperparathyroidism and long-term follow-up data. The cohort in this study is based on a cohort from a previously published nationwide study on permanent hyperparathyroidism, which included all patients undergoing surgery for benign thyroid disease in Sweden between 2005 and 2015. In that study, data was collected from the National Patient Registry, the Swedish Endocrine Surgery Registry, and the Swedish Prescribed Drug Register. In this study, we extrapolated a regional cohort and included all patients who had undergone surgery in Uppsala, Örebro, Västerås, Falun, Gävle, and Karlstad during the same study period. We did a retrospective medical chart review to identify patients with and without permanent hyperparathyroidism using biochemical data with PTH and calcium. Patients were considered to have definitive permanent hyperparathyroidism if they at 12 to 24 months after surgery met one of the following criteria: low intact PTH with hypocalcemia, hypocalcemia without an appropriate elevation of PTH, or at least one failed attempt to unwind the treatment with calcium and/or active vitamin D more than 1 year after surgery. Patients were considered to have possible permanent hypoparathyroidism if they remained at the treatment with no documented attempt to unwind it, or if they remained on the treatment at the time of loss in follow-up. The group with possible permanent hypoparathyroidism were excluded due to the uncertainty of the diagnosis. Health-related quality of life was assessed using SF36 version 2, which covers 8 domains of physical and mental health status and 2 summary scores. An invitation letter was sent out in August 2021, and a reminder letter was sent out to non-responders after 4 weeks. The patients could choose to complete the questionnaire by hand or through a web-based questionnaire. Out of 1,636 patients in the regional cohort, almost 1,500 patients were possible to invite to participate. 716, 48%, answered and were included. Among these, 6.4% had definitive permanent hypoparathyroidism. The vast majority were female and underwent surgery due to thyrotoxicosis, and the mean follow-up after surgery was 11 years. Comparing patients with and without permanent hypoparathyroidism, they didn't differ, with the exception that patients with permanent hypoparathyroidism were younger. This table shows the outcome, so it's the quality of life assessed by the SF36 questionnaire. And as you can see, we found no difference between the groups in any of the health domains or the 2 summary component scores. Since it has been suggested that patients with permanent hypoparathyroidism has an increased risk of death, we also wanted to assess mortality, as an increased mortality among patients with permanent hypoparathyroidism could have affected our findings. However, we found no difference in patients with or without permanent hypoparathyroidism in terms of survival. So, we conclude permanent hypoparathyroidism did not affect quality of life in patients undergoing total thyroidectomy for benign thyroid disease on long-term follow-up. Thank you for your attention.
Thank you very much, Matilda. Let's see if you can get the next slide. Yes. Thank you very much. And our next speaker today is, I think you need to change slide. Matilda finished already. Is Marta Berndsen with a study of young patients with diverticulosis that they have the highest 10-year risk of diverticulitis, a Swedish retrospective observational study. Very much welcome.
Thank you.
Thank you.
Good morning. Thank you for the invitation. My name is Marta Berndsen, and I'm an endocrine and sarcoma surgeon at Sahlgrenska University Hospital. I'm going to present a study that was a collaboration between Sahlgrenska, Karolinska, and Oslo University Hospital called Long-Term Outcome After Surgical Resection of Non-High-Risk Gastrointestinal Stromal Tumours Without Adjuvant Therapy, Consequences for Patient Follow-Up. Gastrointestinal stromal tumor, or GIST, is the most common intra-abdominal sarcoma with a yearly incidence of 15 per million inhabitants. GIST has a heterogeneous nature, ranging from small and indolent to large and aggressive tumors with a poor prognosis. Several risk criteria have been proposed, and the most commonly used is the modified NIH consensus criteria that stratifies patients into 4 risk groups: very low, low, intermediate, and high, according to tumor size, mitotic rate, tumor rupture, and anatomic location. Most national and international guidelines recommend a 5 to 10 year follow-up for all risk groups except the very low risk group. Long-time data is lacking to determine the need for prolonged follow-up for non-high-risk patients that have had localized tumors surgically removed. The follow-up is based on imaging, mainly CT scans, and for patients in the non-high-risk groups, the benefit of repeated radiation exposure is unclear. So the aim of this study was to assess the survival outcomes for non-high-risk patients in 3 large Scandinavian GIST cohorts with long-time follow-up. This was a retrospective multi-center cohort study, including patients with complete resection of primary non-metastatic GIST from Gothenburg, Oslo, and Stockholm. The exclusion criteria were high-risk tumors and patients that had received treatment with tyrosine kinase inhibitors. Medical records were reviewed for clinical details regarding diagnosis, treatment, and follow-up, and correlated to recurrence-free and disease-specific survival. 649 patients were included in the present analysis, 118 very low risk, 381 low risk, and 150 intermediate risk. The mean age was 67 years, and 52% were women. The most common tumor site was the stomach, and thereafter the small bowel. A large portion of the patients had microscopically radical resections, R0. After a median follow-up of 50.5 months, 8 patients out of 649 had experienced a recurrence, given a rate of 1.2%. Of these 8 patients, 5 tumors were borderline in size, meaning that they were 1 centimeter or less from classifying as a high-risk tumor. The recurrence in the intermediate risk group occurred after more than 10 years and is therefore not included in the survival analysis. The 5-year recurrence-free survival was 99.1% for the total cohort, ranging between 98.5% to 100% according to risk groups. The 10-year recurrence-free survival was 96.4% for the total cohort, ranging between 93.8% to 100% according to risk groups. As this Kaplan-Meier graph clearly demonstrates, there was not a statistical difference between the risk groups. The 10-year disease-specific survival was 99%, ranging between 98.4% to 100% according to risk group. Here, it is also clearly demonstrated that there is not a significant difference between the risk groups. According to these results, we conclude that there is not that the long-time recurrence-free and disease-specific survival in non-high-risk GIST is excellent. We did not find a difference in outcome between the intermediate, low, and very low-risk groups, and therefore suggest to merge them to one low-risk group. Tumours close to the cutoff in size and mitotic frequency could be upgraded to high risk on individual basis. 83 patients need to be followed up to detect one recurrence, and according to our Swedish national guidelines, patients in these risk groups undergo 15 CT scans during their follow-up, which adds up to over 1,000 CT scans to detect one recurrence. This is both a health economic issue, but also a term called fear of cancer recurrence has been shown to negatively influence patients' quality of life during follow-up without any correlation to disease severity. So taken together, our findings indicate that routine follow-up to detect disease recurrence should not be performed in non-high-risk GIST. Thank you.
Thank you, Marta, and I'm very happy that you actually talked about the right subject, because we presented the wrong title if some of you were awake and noticed that. But still you told us about the GIST tumors. We're really happy about that. Thank you. Our next speaker will talk about what I said previously. Young patients with diverticulosis have the highest 10-year risk of diverticulitis, a Swedish retrospective observational study. And this is Pamela Buchwald. That are very welcome.
Thank you.
Thank you.
Thank you very much for letting me present. I am presenting on behalf of medical students Hugo Delveus and Gustav Lansing, and my PhD student Hanna Sali. Diverticulosis is herniation through the colonic wall, most commonly found in the sigmoid colon. And the frequency of diverticulosis increases with ages. And the incidence of complication, that is diverticulitis, is supposedly increasing in the Western population. As diverticulosis is often asymptomatic, the true prevalence of the condition is elusive. The aim with this study was to examine the prevalence of diverticulosis in a study cohort undergoing colonoscopy and investigate the incidence of diverticulitis during a 10-year follow-up. This is a retrospective observational study. All patients undergoing colonoscopy at the endoscopy unit, Skåne University Hospital, Malmö, between 2010 and 11 were eligible, and colonoscopy referrals, colonoscopy reports, and medical records were reviewed until June 2022. In all, we identified 4,612 patients. However, a little bit more than 1,100 patients needed to be excluded because the colonoscopies were performed by private healthcare providers. 558 of the examinations were cancelled, either because of the hospital or patient reason. 45 of the patients had previously undergone sigmoid resection and were therefore excluded. And 50 of the examinations were aborted, which left us with 2,855 patients. Of these patient cohort, 53% were women, and the median age was 62 years. And for almost 38% of the patients had diverticulosis at the index colonoscopy. And during the 10-year follow-up, only 83 patients, or 2.9% of the population, developed diverticulitis. As expected, the patients that developed diverticulitis more commonly had diverticulosis, and the reason for performing colonoscopy was more commonly diverticular disease. The follow-up time was similar in the both groups. During the 10-year follow-up, the overall incidence of diverticulitis verified by CT was 6.7% in patients with diverticulosis and only 0.6% for patients without diverticulosis. And when performing Cox regression analysis, the hazard ratio for patients with diverticulosis, the risk to develop diverticulitis was 9 times higher when adjusted for age, sex, and previous diverticulitis. Almost 40% of the patients with diverticulitis had previous diverticulitis, and 41% of the patients had complicated diverticulitis, and 59% of the patients had uncomplicated diverticulitis. During the follow-up period, 27 patients with diverticulitis needed sigmoid resection due to diverticulitis. The frequency of diverticulitis tended to increase with age, but the highest relative risk of developing diverticulitis had patients in the younger age group, that is, they were under 41 years. This study has several limitations: the retrospective design and the risk of selection bias. We don't know if the prevalence of diverticulosis found in our study is generalizable to a larger population. However, all the colonoscopy reports were standardized and the examinations were routinely photographed. And we performed random sampling of the patient cohort to verify the result. And we also reviewed all imaging taken during the investigations in the patients without diverticulosis at index colonoscopy that developed diverticulitis. Also, in order to have a diverticulitis diagnosed, this needed to be CT verified, and that required either a visit at the emergency department or admission, and therefore we may have missed uncomplicated diverticulitis treated by the GP. So, in conclusion, diverticulosis is a common condition in the population. Older patients have a higher prevalence of diverticulosis. Few patients with diverticulosis develop diverticulitis, but younger patients have a higher relative risk of developing diverticulitis. And we need to have a higher readiness for symptoms of diverticulitis, increased information, and maybe undertake prophylactic measures may benefit young patients with diverticulitis. Thank you very much.
Thank you, Pamela. And then we will have our next presenter, which is Emelie Nilsson, who will talk about low risk of recurrence in high-risk T1 colon cancer, equal outcome following endoscopic and surgical resection. Very much welcome.
Thank you. Thank you. Okay, thank you for the invitation. Yes, so my name is Emelie Nilsson, and I'm going to present to you our study that is called Low Risk of Recurrence in High-Risk T1 colon cancer, equal outcome following endoscopic and surgical resection. So advances in endoscopic resection techniques as well as implementation of screening have increased the proportion of T1 colon cancer that is amenable for endoscopic resection. However, the majority of the patients still get a surgical resection, even though and despite the benefits of a bowel preserving endoscopic resection with that comes with less morbidity, less mortality, and less costs. And the main reason for this is that there is a fear of leaving concomitant lymph node metastasis in the patient, which constitutes of approximately 10% of all T1 colon cancers. And to deal with this risk, European guidelines have been formed to divide endoscopic resected tumors into high and low risk tumors. And if the tumor had one of the following: lymphovascular invasion, tumor budding, a high grade, a submucosal invasion that is 2 or 3, or an R1 resection, it's categorized as a high-risk tumor, and the patient will be recommended a subsequent surgery. Okay. So the problem with this is that over 60% of the patients get categorized as high risk with high-risk tumors. And studies have shown that those patients that actually get the subsequent surgery, only 5 to 15% of those actually have lymph node metastasis. And it's also important to recognize that the risk is based on risk factors of lymph node metastasis and not the actual clinical outcome. And the clinical outcome is sparsely investigated. So this means that we do a lot of unnecessary surgeries. So our aim was to compare recurrence after surgical and endoscopical resection of T1 colon cancer, but also to identify risk factors of recurrence. We used the Swedish colorectal cancer registry, which is a retrospective national cohort study with prospectively collected data. And after exclusion of factors including metastatic disease from the beginning as well as neoadjuvant treatment, we ended up with a study population of 1,805 patients. We calculated the 6-year cumulative recurrence. We looked at disease-free interval. We illustrated these results with a Kaplan-Meier curve and compared with log-rank tests, but we also estimated the risk with Cox proportional hazard regression, both crude and adjusted analysis. And finally, we looked at our material and divided in high and low risk tumors according to the European guidelines. However, tumor budding is missing in the registry, so that we could not include. So if we look at the results, the cumulative recurrence in the surgical resected patients was 3.6%, and in the endoscopic resection was 3.7%, so very similar and low. The 5-year disease-free interval was 96.2% among the surgical resected, and the endoscopically resected patients, 95.6%, so high. If we look at this Kaplan-Meier curve, I see now that the colors are very similar, but the blue color, it represents the surgical resected, and the green color, the endoscopically resected patients. And you can see it's on top of each other. So visually, we cannot see any difference. We did a log-rank test, no statistically significant difference, and we also did a Cox proportional hazard regression, where we got a hazard ratio of 1.03. And as you see, the 95% confidence interval clearly includes 1, so we cannot find any difference here. The recurrence in the different risk groups, if we start to look at the low-risk group, the surgical resected had a recurrence of 3.6%, and among the endoscopically resected, there was 1.7%. After Fisher's exact test, there was no difference here. We looked at the high-risk groups. The surgical resected had a recurrence of 3.8%, and the endoscopically resected 5.4%. Chi-square test could not see any statistically significant difference. We also added a third group that we call indeterminate, and those are the patients that we couldn't categorize due to missing values, but we wanted to anyway include them too, so you can see here, and there was no difference here as well. Finally, we looked at individual risk factors, gender, age of diagnosis, histologic grade, lymphovascular invasion, mucinous type, submucosal invasion, and location of tumor in the colon. And the only risk factor that was independent was lymphovascular invasion, with a hazard ratio of 3.73. So that's a high number, and it's clearly statistically significant. So we conclude that there was no difference in recurrence for T1 colon cancer comparing endoscopic and surgical resection, not even in the high-risk lesions. Lymphovascular was the only independent risk factor of recurrence, and we believe that these results challenged the current guidelines recommending subsequent surgical resection to all high-risk T1 colon cancer patients. Thank you so much.
Thank you very much, Emelie. And now to the last presenter of today's BJS nominated to the BJS Prize, Roberto Rosén. He's going to talk about distal tumor location is an independent risk factor of recurrence in early rectal cancer. Welcome.
Thank you. Hello, first of all, thank you so much for giving us the opportunity to present our study. My name is Roberto Rosén. I'm a PhD student at Lund University and also a surgeon at Skåne University Hospital in Malmö. So our study, named Distal Location, is an independent risk factor of recurrence in early rectal cancer. Yeah, I'm going to present this study. So a bit of background, as you now know, risk factors for lymph node metastasis in T1 rectal cancer dictates the treatment strategy, whether to perform local resection or surgical resection. And these risk factors are based on histopathological features. However, impact of tumor location within the rectum is poorly investigated in cases of early rectal cancer. The results that are available are conflicting, and we think, or there might be potentially some place or room for optimization of organ-sparing strategies for these patients, if we investigate this aspect. So the aim of this study, of our study, was to investigate the impact of tumor location within the rectum in early rectal cancer as a risk factor for lymph node metastasis and recurrence. In order to perform that, we gathered data from the Swedish colorectal cancer registry. We included patients with T1, T2 rectal cancer. And we constituted two cohorts, as you can see. First cohort, LNM, lymph node metastasis cohort. We excluded patient included in this cohort. First, were excluded for or patient that had undergone neoadjuvant treatment and local resection were excluded, and the patient left constituted the lymph node metastasis cohort. Secondly, we constituted a second cohort, recurrence cohort, by excluding patient that had distant metastasis at diagnosis and patient lost to follow-up. If we look at methods, we had some missing values, and we used multiple imputations to deal with these missing values. If we look at how we investigated impact of tumor location and on lymph node metastasis, we used logistic regression. To study tumor location or impact of tumor location on recurrence, we used Cox regression analysis. In this case, we set the follow-up period to 6 years. And importantly also, but it's not easy in the available literature, the definition of tumor height, as you can see here, we defined the distal part as located between 0 and 5 centimeters from the dentate line, the mid part of the rectum as located between 5 and 10 centimeters, and the proximal part as located between 10 and 16 centimeters. If we look at the results now, if we look at the impact of tumor location on lymph node metastasis, we can see that proximal location is significantly associated with higher rate of lymph node metastasis. Among other factors, age, lymphovascular invasion, perineural invasion, and high histologic grade were also significant. If we continue and look at impact of tumor location on recurrence, we can see that in this case, distal location, early rectal cancer was significantly associated with higher recurrence rate. Among other factors, sex, T-stage, nodal involvement, and lymphovascular invasion were also associated with recurrence. Another way of illustrating this, we can see that in red, the red curve represents the patient with the distal cancer or rectal cancers. They have worse outcome during the follow-up. As a conclusion, distal tumor location is a strong and independent risk factor of recurrence in early rectal cancer, and tumor location should be taken into consideration in the management of early rectal cancer. Thank you so much for your attention.
Thank you very much. Thank you. Yes, thank you very much. Unfortunately, we don't have any time for questions. But now it's the really exciting moment when you are going to hear about who the second and first winner is. And I would like to call then, we have our slides here, yeah. I would like to call Emelie Nilsson up to the stage for the second prize. And you will receive then this, the diploma, and also 1,500 €500. And this was then for the low risk of recurrence in high risk T1 colon cancer, equal outcome following endoscopic and surgical resection. And the motivation from then the editors at the BJS and the Committee for Surgical Research was that this prize is for a timely cohort study showing the feasibility and oncological safety of endoscopic surgical resection in a defined subgroup of patients with colon cancer. Congratulations. You can stay there, yeah. And the winner is Marta Berndsen. She will win then the first prize, which is €3,500 for her long-term outcome after surgical resection of non-high-risk gastrointestinal stromal tumours without adjuvant therapy, consequences for patients' follow-up. This time the title was right. And the motivation from then the group of referees were for a well-conducted binational registry study supporting tailored surveillance of gastrointestinal stromal tumours guided by the risk of recurrence. So very much congratulations. So we hope we can read your papers in the BJS in the future. Yes.
Thank you.
Thank you. And thank you to the rest of you. They were excellent studies also, but it's only 2 winners.